Hello, and welcome to the University of Washington, Washington Area Cardiometabolic Project Echo Session 4. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington Diabetes Institute. So today we're really excited to have Dr. Savitha Subramanian, who's going to continue the lectures on older diabetes medications, but she'll be focusing on DTP4 inhibitors and TZZs. As well, Dr. Lorena Wright from our own Latinx clinic here at the University of Washington Diabetes Institute will be presenting an interesting case. And now I'm going to ask the rest of the panelists to introduce themselves as they will be helping to direct the discussion. So Dr. Subramanian, please introduce yourself.
Hi, Nicole. Hello, everyone. Savitha Subramanian. I'm an endocrinologist here at the University of Washington. My two big hats are lipids and diabetes. I'm the medical director of the lipid clinic at South Lake Union.
Thank you. And Dr. Barbara Uneman, coming to us from the East Coast, can you introduce yourself?
Hi, good afternoon, everyone. Barbara Onoma. I'm an adult endocrinologist and I practice in Maryland.
Thank you so much. And Dr. Lorena Wright?
Hello, I'm Lorena Wright. I am an adult endocrinologist, director of the Latinx Diabetes Clinic at the Diabetes Institute in Seattle.
And finally, we have our great certified diabetes educator coming to us, Anna Barash. Go ahead, Anna.
Hi, everybody, and thanks for having me. I'm Anna Barish. I'm a diabetes educator, like Nicole said, and I work primarily at Benaroya Research Institute with people diagnosed with diabetes and in the community doing community education.
So now, without further ado, Savitha, go ahead and start lecture 4 for the cardiometabolic echo.
Thank you, Nicole. So today my lecture is going to be, for the next 30 to 35 minutes, we'll review the two older medications, the thiazolidines and the DPP4 inhibitors, which have kind of fallen way to the bottom of our diabetes armamentarium. So these are the two objectives. So we're going to look at review the mechanism of action, efficacy, and safety profiles of both pioglitazone, the primary TZD that most of us use these days, and DPP4 inhibitors as a class, focusing on cardiovascular, renal, and liver effects. So here's our index patient. So we're going to look at this individual and see if we can help him. He's a 54-year-old male who's had 5 years of type 2 diabetes and has no complications, either microvascular or macrovascular. He's on metformin, maximized 1,000 milligrams twice daily. In the past 2 years, he has a new job. He works primarily from home, and he's gained 12 pounds due to lesser physical activity. He wanted to lose weight, so a GLP-1 receptor agonist injectable therapy was actually attempted, but he developed severe reflux, and so he stopped it and decided he wasn't ready to try a different agent at this point. He's actually has self-pay for insurance at this point because he has a small business owner, so he insists that he cannot afford an SGLT2 inhibitor, so we're going to set that class of medications aside. And in the last 12 months, as you can see here, his A1Cs have steadily risen. So think about this patient and think about what the next steps could be for this individual. So as you all are very well aware, glycemic control actually declines with time when a single drug is used. And most of us use metformin as primary initial therapy. And with time, on the left here, you see treatment with metformin. At 3 years, only 44 individuals have an A1C that's under 7. And at 6 years, it's only 34% of individuals who are on metformin monotherapy and declines with time. With sulfonylureas, it is pretty similar. So the point here is with traditional therapies to maintain glycemic management, glucose is under optimized levels, we're going to need to add medications. And why is that? So this was shown even about studies are now over 25 years old. The UKPDS, which was a landmark study published in 1998, showed that even with intensive controls shown here in this red light dotted line, I'm not sure if you guys can see my mouse, but the lower line, thank you. The intensively treated group also with time, the A1C starts to drift up. And the reason for this is when an individual is diagnosed with type 2 diabetes, there's already a decline in the number of beta cells in the pancreas. So they do not start at 100% beta cell function. And it's hard to know where they start, but with time, the beta cell function just declines. And you can think of this as aging of the pancreas. And this happens, and this is called diabetes progression. And this is the reason why we need to add therapies to our patients with diabetes. So here is the traditional list of all the therapies. Oral as well as subcutaneous also features here that we have used to add to metformin therapy. And the two classes that I'm going to focus on are the DPP-4 inhibitors and the thiazolidinediones. And I will start off with the TZDs first and then go to the DPP-4 inhibitors. Now, as you have probably heard in previous lectures, the American Diabetes Association releases the standards of medical care in diabetes every year. It's an active living document and gets updated every year. And this very complex algorithm which has evolved over the last 4 or 5 years, is what our current thought process is for managing diabetes. I don't expect you to read this, but you will need a magnifying glass to look and see where the DPP-4 inhibitors and the TZDs actually feature. So these two boxes here, so this is under glycemic management. In very small print here, it says DPP-4 inhibitors, and there's DPP-4 inhibitors here. Actually, I don't even know where the TZDs are. Oh, here, right here. So this is under high efficacy for glucose management, and for weight neutrality is DPP-4 inhibitors. So anyway, you have to look really closely to see where these older drugs feature nowadays, because we've kind of moved away from using these older medications for a variety of reasons, which you will hear about in future lectures. So what does this algorithm actually tell us to do? So we have to identify patient characteristics. And the first question you want to ask is, does this individual with diabetes have cardiovascular disease, renal disease, or any other high-risk features which might want you to pick a certain medication? But our patient that I presented in the beginning doesn't have any of those features. And for him, it's primarily glycemic management and weight management and cost considerations. So this is where you want to look in the algorithm of the American Diabetes Association. So what does the ADA say in 2024? So in adults with diabetes and cost-related barriers, consider use of lower-cost medications for glycemic management, that is metformin, sulfonylureas, thiazolidinediones, and human insulin, within the context of their risks for hypoglycemia, weight gain, cardiovascular and kidney events, and other adverse effects. So with that, let's talk about so my assigned topic is TZDs and DPP-4 inhibitors. So that is the reason why I'll be focusing on just these two drugs today. So the thiazolidinediones, which is what we're going to talk about first, include pioglitazone and rosiglitazone. These drugs have been out since the late 90s, early 2000s. I want to point out there was another TZD, troglitazone, which was taken off of the market because of liver damage. These drugs, the pioglitazone and rosiglitazone, were some of the highly prescribed anti-hyperglycemic drugs between 2000 and 2008. So how do these drugs work? So again, I'm going to focus on pioglitazone primarily for reasons I will highlight in a couple of slides. So how do these drugs work? So as a class, these are selective agonists of the nuclear receptor PPAR gamma. So this PPAR gamma is present in certain cells in the body. So it's primarily adipose tissue and skeletal muscle, and also a little bit in the liver. It increases. So when you give a TZD, it goes and agonizes or attaches to the PPAR gamma receptor, and this results in increased insulin sensitivity. In the adipose tissue, it actually helps break down fatty acid and increase fatty acid uptake. And in the skeletal muscle, it actually improves glucose utilization. So all of these improve insulin sensitivity. In the liver, it decreases gluconeogenesis, so it suppresses liver glucose production. It lowers fasting and postprandial blood glucose. And they're actually very effective A1C reducing medications. They lower A1C anywhere from 1 to 1.5%. But because these work on an intracellular nuclear receptor, it takes about 3 months to see a full effect, as opposed to if you use metformin or sulfonylurea, you'll see the effect within a few days. These agents also have a more durable glucose lowering effect than sulfonylureas. So what about cardiovascular effects with TZD. So the proactive study was a study that was published in the Lancet in 2005. I want to point out this was probably the first cardiovascular outcome trial of an anti-hyperglycemic drug. So nowadays, since 2008, when there were a lot of FDA regulations, we have CVOTs for every single drug that has come out since then. But this actually was probably the first one. So what they did was they took over 5,000 individuals with type 2 diabetes and known macrovascular disease and gave them either pioglitazone or placebo. They could titrate the dose of pioglitazone, which started at 15 milligrams, can go up to 30 or 45. And the patients were followed for about 3 years. And so the primary endpoint, so in these cardiovascular outcomes trial, what this study used was a composite of all kinds of different endpoints. So here it was a composite of all-cause mortality, non-fatal acute coronary syndrome, endovascular surgical intervention in the coronary, so including CABG or leg arteries, and amputation above the ankle. So this was a very diverse endpoint here. And unfortunately, the study did not show a difference in primary endpoint. So this was not statistically significant. So it did not improve cardiovascular outcomes as a primary endpoint. But the secondary endpoint, which was also pre-specified, which was a composite of all-cause mortality, non-fatal MI, and stroke, was actually statistically significant. You can see the divergence here, and this was about 16% relative risk reduction. And this was a secondary endpoint. So there was a lot of this. The results from the study came under a lot of scrutiny because this first primary endpoint has a lot of diverse endpoints included, including amputation, which is typically not included in current CVOTs. So this was some people consider that the reason for the study to be negative, and that if this was not included, this might have turned out to be a positive study. So anyway, that said, there were some signals in proactive which actually need to be highlighted. So although there was some potential benefit from the cardiovascular side, even though not statistically significant in the primary endpoint, but only in the secondary, the folks who were in the pioglitazone arm had a lot more hospitalization for heart failure. And there was increased risk of edema, and also not due to heart failure, as well as heart failure hospitalization. So there was no mortality from heart failure, but there was just a significant increase in this signal. And so that needs to be pointed out here. So before I move on to this IRIS trial, which was the most recent one using pioglitazone, so that proactive study was in 2005. In 2007, with rosiglitazone, there was a meta-analysis that was published by a cardiologist from Cleveland Clinic, Steve Nissen, who highlighted that rosiglitazone, the other TZD, caused a lot of increased the risk of myocardial infarction. And so there were two meta-analyses that came out, his and another group of authors. And so this highlighted that maybe there was cardiovascular safety issues of rosiglitazone. And so the FDA jumped in and pretty much said all drugs have to go through rigorous cardiovascular outcomes trials. And that is why we have all these CVOTs that are happening these days. And so it turned out to be the death knell for rosiglitazone because of the so-called meta-analysis. But since then, that's been debunked that there's actually not a cardiovascular signal with rosiglitazone. However, it just hasn't picked up. And so nobody really prescribes rosiglitazone anymore, even though it is actually available. So time passed, and in 2016, the IRIS trial was published, which is actually quite promising. So this was a study which included about 3,800 individuals divided into two groups. These are not people with diabetes, but with insulin resistance that was diagnosed with a HOMA-IR. So using plasma insulin level and glucose, it's a formula. And so if the cutoff for HOMA-IR was above 3, they were classified as insulin resistant. And these people had recent TIA or strokes, and they were randomized to either pioglitazone or placebo. The pioglitazone was given at a steady dose, single dose of 45 milligrams, which is the highest dose. So what did they find? They actually found that the pioglitazone decreased risk of non-fatal MI and stroke. That was the composite endpoint by about 24%. So this was a positive study, and it also decreased acute coronary syndrome by about 29%. So this was the authors didn't really have an explanation for why this is, but pioglitazone actually improved insulin resistance as expected, decreased plasma glucose, prevented progression to diabetes. And in this study, there was no increased risk of heart failure. The incidence of heart failure in both the groups, the placebo as well as the pioglitazone group, was pretty equal. And so here's the risk of stroke with pioglitazone versus placebo, shown here in a bar graph. So then all the pioglitazone studies were entered into a meta-analysis. And so this was published in 2017. So what can we see here? In people with prediabetes and insulin resistance, there is actually an improvement in decrease in major adverse cardiovascular events, the relative risk of about, I don't know, 29, 30, 20 something percent here, and decrease in relative risk of MI also by about 30%. And similarly, in people with type 2 diabetes, it looks like there is a slight improvement in major adverse cardiovascular events when you, when you put all the pioglitazone studies together. So this was a meta-analysis. So what does pioglitazone do to cardiovascular risk factors? It actually, from all the studies, now we can, it decreases hypertension, decreases triglycerides, increases HDL. It decreases the sticky LDL, the small dense LDL, decreases inflammation, decreases blood glucose, and insulin resistance. So in general, it tends to improve cardiometabolic health. What about effects on the kidney? Do we have any data? Some of the studies have shown an improvement in urinary albumin protein excretion, but there's no studies that have been done in people who have lower eGFRs under 45 or under 30. So we don't really know if there's any benefit, but there seems to be an improvement in albumin. How about effect on the liver? The PIVEN study looked at this, and this was a study of people with biopsy-proven metabolic associated steatotic liver disease with or without diabetes, and they were given pioglitazone or placebo or vitamin E. And what it showed was the pioglitazone arm showed an improvement in hepatic fat and decrease in steatosis. And this happened at any stage of the liver disease when the study was conducted for about 2 years. And when the pioglitazone was stopped, there was an increase in ALT levels, as you can see here. And that also happened in the vitamin E arm. But either way, so even though there's an significant improvement in features of metabolic associated steatotic liver disease, it's not really an FDA-approved treatment for this condition. What about safety concerns? So weight gain is a big problem with these agents, as you all are aware. You can gain about 1 to 4 kilos of, this is adipose tissue mass that actually is gained. It's dose-related. Higher doses improve A1C and improve insulin resistance, but it also results in greater weight gain. The reason for this is this weight gain is actually expansion of the subcutaneous fat tissue. It is not intra-abdominal fat. It is because the PPAR gamma receptors are stimulated in the hypothalamus and the appetite center, and so it causes a slight increase in appetite. But this weight gain actually happens in the subcu tissue, which is interesting. And you can hopefully avoid this by limiting the dose to the middle dose, which is 30 milligrams. Edema is a big signal that's seen in all the studies. Why? Probably because of urinary sodium retention. And this was from the early studies. This is data from the early proactive study. The edema from pioglitazone does not respond to loop diuretics or thiazides. You have to give spironolactone or trimethoprim, one of the diuretics that affect the distal tubule. You want to be really cautious in people if they have heart failure. This is not a drug you want to use, or if there's edema on exam. There is some data that suggests that it can improve diastolic dysfunction. Bone fractures, there's a signal that has been seen, as well as bladder cancer. So what do we know? So looking at the meta-analysis of all the trials that I showed you for the cardiovascular data, this is kind of hard to see, but I will just use my mouse and point out that for heart failure, there is a slight increased risk. Fracture risk may be present, not super strong, but the biggest risk is for edema and weight gain. There's a slight bladder cancer risk when you put the two studies that they looked at was IRIS and proactive, and IRIS didn't have increased bladder cancer risk. So it's slightly increased. So I'd say there may be a mild risk, and that's why there's a warning, FDA warning that you have to be careful about risk of bladder cancer when you use these agents. So to summarize what I just told you about TZDs, it's an excellent insulin sensitizer with good A1C reduction, may have cardiovascular risk reduction benefits, but you have to be cautious because the use is limited by weight gain and edema. And if someone is wanting to lose weight, it can be very upsetting. We used to use a lot of TZDs in the 2000s, and this was always an issue. The weight gain was always problem. So something to keep in mind. Moving on to the DPP4 inhibitors, and it should be done in the next 8 to 10 minutes at the most. So I want to talk about the incretin effect. You may have heard about this already, but it's good to review it again. There are two hormones that come from the gut, GLP-1, that's glucagon-like peptide 1, and glucose-dependent insulinotropic GIP. So these are the hormones that are responsible for the incretin effect. So what is the incretin effect? So if you give or IV glucose. So let's say you give 50 grams of IV glucose, the glucose will cause the pancreas to release insulin, and that's this red line here on the left figure. However, if you give the same glucose orally, 50 grams of oral glucose, the amount of insulin the pancreas secretes is significantly higher. So this difference in insulin secretion that happens in healthy patients from the difference between IV and oral glucose loads is because of the hormones in the gut, and this is called the incretin effect. And these two hormones that I mentioned are the reason for this incretin effect. Now, diabetes can be, if you look to the right here, diabetes can be considered an incretin deficiency or an reduced incretin effect because you don't get that same peak after an oral glucose load as you see in healthy patients. You see that peak is blunted, and so the reduced incretin effect, and so is the reason why the incretins have been a target for drug development in diabetes, type 2 diabetes. So GLP-1 mechanism of action, to review, on the brain, it works on the appetite center and decreases appetite. This can result in reduced body weight. On the stomach, it decreases gastric emptying, decreases postprandial hyperglycemia. And on the pancreas, it increases insulin secretion and decreases glucagon. So these are just very simplistically to remind you of GLP-1 action. So where do the DPP-4 inhibitors fit in? So there's endogenous GLP-1 that your intestine makes and releases into the circulation. So if you block the destruction of endogenous GLP-1, you can increase the duration of your own GLP-1 longer, and that's the enzyme that breaks down GLP-1 is called DPP-4. So this is the enzyme on the right here that inactivates your own GLP-1. So if you block that with a DPP-4 inhibitor, then you can increase the concentration in the blood of intact biologically active GLP-1, which can then work with the different GLP-1 receptors. So that is the principle of use of these DPP-4 inhibitors. So how do these drugs work? Pretty much it just makes your own GLP-1 work well. So the figure I showed you on how GLP-1 works is how these drugs make your own GLP-1 work. The DPP-4 inhibitor as such doesn't have an effect. The effect is from inhibiting the GLP-1 in your body. So the different DPP-4 inhibitors that we have are sitagliptin, saxagliptin, linagliptin, and alogliptin. They're not very powerful A1C lowering drugs, only about 6 to 8% if you're lucky. They're very weight neutral, so they do not cause any weight gain or weight loss. There's no risk of hypoglycemia, and you have to adjust the dose for renal insufficiency, except for linagliptin. Often this is something that's asked on the boards if you're interested. However, I couldn't find any generic GLP-1 DPP-4 inhibitor. I thought sitagliptin was, but doesn't seem to be. So they're still expensive. Can be about $100 a month if you're paying cash price. So what are the cardiovascular effects of these drugs? Weight neutral, doesn't do anything to the weight. Blood pressure may be a minor decrease based on some of the large cardiovascular outcomes trials. They do cause modest reduction in triglycerides after a meal. So that's postprandial hypertriglyceridemia, which has been associated with increased cardiovascular risk. Now, if you look at all the cardiovascular outcomes trials, all of these were done after 2008, after that rosiglitazone saga I told you about. These have turned out to be safe to use, meaning there's no negative cardiovascular signal, but there's no benefit. So meaning if you give a DPP-4 inhibitor, you're not going to protect against cardiovascular disease. So what about kidney effects? So there's one study that has looked at this, that's the Carmelina, where the secondary outcome composite, they had a kidney outcome. It seemed to decrease. So this figure on the right here, the panel A is cardiovascular outcome. It was a negative, meaning it was a cardiovascular neutral study. If you look at the kidney outcome is on the right side, panel B, there may be a slight improvement in albuminuria progression, but there was no benefit to the composite kidney outcome. So again, both the lines are completely on top of each other. So really no significant kidney benefit. Liver effects, again, also nothing much to speak about. It doesn't really do much to liver fat or transaminases. So really not something you would use. So they're safety-wise, they're safe. There's no pancreatic cancer or pancreatitis signal that's been noted in any of the studies, and all the meta-analysis have looked at this. There was even one published last year or this year, and it was a negative pancreatitis or pancreatic cancer signal. There's no immune effects. There was some suggestion that these drugs may cause some immune changes and increase risk of infections, but that's not really panned out. There is a signal for increase in heart failure hospitalization in one of the saxagliptin studies, that's the SAVOR-TIMI, but this was only for saxagliptin. So I would encourage caution in people who have a history of any kind of heart failure. So, but it doesn't seem to be a class of it. Vildagliptin is available in Europe, not available in the US. There's some suggestion of maybe it increases left ventricular volume, but there's no increase in heart failure. One study showed increase in liver transaminases, but it's not available for us to use, so I wouldn't worry about it. It seems to be safe to use you can use it as monotherapy since it's pretty weight neutral and doesn't really cause any other side effects. It's good for use in people who have CKD, elderly, who really don't want to add injectables, or just you want like modest A1C lowering. The last slide here that I have, and then I'll wrap up, is the GRADE study, which is the most recent study, which was published about 2 years ago in the New England Journal of Medicine. So this study looked at 5,000 people with type 2 diabetes on metformin. And what they did was they added different agents as second agents to metformin. So it was either a sulfonylurea, a DPP-4 inhibitor, it was sitagliptin, branded Januvia, liraglutide, Victoza, or insulin glargine. And then they followed these folks to see how long it would take with the dual therapy to get to A1C over 7%. So they're looking for treatment failure. And what they found was, this is kind of hard to see, but what I want to point out here is the worst was the DPP-4 inhibitor. Sitagliptin really didn't do anything. It was the first one to get where the people on the sitagliptin arm were the ones who had their A1C start to rise, didn't do anything for anything pretty much. That's the red line here. The red is the sitagliptin. If you want to take a look later or, magnify it on your screens, yellow is the sulfonylurea. They used glimepiride. And then the GLP-1 and insulin were the best for most of the outcomes. So food for thought about the DPP-4 inhibitors. I will say one of my internist colleagues said it's a whole lot of buck for not enough bang on DPP-4 inhibitors, unfortunately. So anyway, back to our patient. So here's our guy who's on metformin, and his A1C, he needs therapy advancement, doesn't want to do he's tried one GLP-1 receptor agonist. There are some cost issues. We're not going to go GLP-1 or SGLT2 inhibitor. So I'm going to open up the floor to kind of talk about what you might want to do. So would we add a TZD? Would we add a DPP-4 inhibitor? What are our options here? And there's no right or wrong answer. This is a discussion with the individual because it's a two-way street. So I'm going to start off by saying that the DPP-4 inhibitor, as I said, is weight neutral, but the A1C reduction is only about 0.6 to 0.8% if you're lucky. Also, he's self-pay. He's going to have to pay out of pocket for this, and it'll cost him probably $90-100 a month. So I don't know that I'd pick a DPP-4 inhibitor for this gentleman. The TZDs, and he could definitely benefit. It can lower his A1C. It will cause weight gain. And it's, as I said, it's pretty cheap. So that is an option, but you have to lay out the side effect profile to him. But I'm curious to see what others would do on our panel.
I think I would choose pioglitazone. I understand that he doesn't want to lose weight, but I always come back to the objective of treatment. So our first priority is to improve his glycemic control. And so that's how I always present it to my patients. I tell them that we have certain goals that we want to achieve, and improving glucose control is one of them. And pioglitazone can lower their glucose by 1 to 1.5%. And if it works well with lifestyle modification and his insulin levels reduce, his endogenous insulin production reduces, then that will help him hopefully not have as much cravings and that might also help him not put down as much fat, and that indirectly might help him actually balance out some of the weight gain that he might get from the medicine. So some of it is edema, but some of it is also, we know he has subcutaneous fat deposit, but some of it might also be offset by reducing his insulin production endogenously. So that's how I would present it to him.
Yeah,
and
thank
he
you,
can
Barbara.
afford that.
Lorena, maybe I'll give Lorena a chance so we can wrap up my talk and move on to her. Lorena, what would you do, Dr. Wright?
Yeah, I think, it's tough again, right? Like because of the weight issue. I would probably do insulin and then or pioglitazone, but I would probably prefer insulin first.
So you would do insulin. Okay, basal insulin. Okay. I'm going to throw out another option here. So there is through Mark Cuban's pharmacy an SGLT2 inhibitor called brexpiprazole, Brenzavi, and it's $40 a month. So there is that option, which could be considered. Again, SGLT2 inhibitors are not the best A1C lowering drugs, but I just wanted to bring that up and throw that out there so that people are aware. Yeah, so that's an alternative option. Yeah, the tirzepatide Dr. Earhart mentioned is, it's cost prohibitive if you've got self-pay. So there is an option through the Eli Lilly website for people who want weight loss. You can actually buy it for $400 a month at the 2.5 milligram dose weekly, and a little bit higher for the 5 milligrams. So that's a new availability. But again, it's not cheap. So anyway, I will wrap up with that. I do have a summary slide, but I'm going to pass the baton on to Dr. Wright, who's going to present the next our clinical case, and then Dr. Onuma will be the discussant.
Thank you, Savita. Yeah, so then this is a case that I think has several points that I thought were very interesting, and it's a patient I just recently saw. This is a gentleman. He is 47-year-old. He has a history of diabetes, and his last A1C is 7.8. He also has coronary artery disease. The status was gastric bypass ×3 recently, like in January of this year. He has obesity, metabolic associated cirrhotic liver disease. And with that hemoglobin A1C, he is reluctant to start insulin. And I'll tell you about the medications that he's on in a minute. As I said, his diabetes has been historically poorly controlled. The highest A1C has been 10.6. And what happens a lot of times is that he would, his A1C would go up, and then he would have a discussion with his primary care provider. And primary care provider would want to escalate, like the treatment, and he would be like, no, I'm going to do like better, like I haven't done my best. And then, like he does better, his A1C gets better, but doesn't really get to where it needs to be. It doesn't really get to goal. And then it goes up again, and that kind of thing. I'm probably sure that you had patients like that. So, and now, his A1C has plateaued. It's been kind of like 7.8, 7.7, like in the last year. So the questions I have is, what would you recommend for his dyslipidemia? And again, I'll go through the medications in a minute. Considering he has coronary artery disease, he's already on a max dose of rosuvastatin. And also, I'll tell you more about the other comorbidities that he has. As I mentioned, he has type 2 diabetes, coronary artery disease, a bypass in January, hypertension, dyslipidemia, sleep apnea. He says that he doesn't use his CPAP. He doesn't like it at all. He can't sleep. He's super uncomfortable. He just doesn't like it, doesn't use it. His BMI prior to the gastric bypass, heart bypass, is 37, and it continues to be 37. He is on metformin, tolerating well. He's tolerating all of his medications well. He is already on tirzepatide, 15 milligrams, empagliflozin, losartan, metoprolol, rosuvastatin, 40 milligrams, and vidogrel, 25 milligrams. Doesn't have any allergies. He has a family history of diabetes in mom and both of the grandparents. Doesn't have a history of heart disease, as far as we know. He just recently got married in the summer, and he went on his honeymoon. And he doesn't smoke, but he does have a significant alcohol use. He on average drinks 35 cans of beer a week. And part of this, and he recognizes this, is that what he does for a living is entertainment, kind of like entertainment. So then he meets with clients and, takes the clients to events, and, there's quite a bit of drinking at work, basically. His physical exam, his weight is 260 pounds, BMI is 37.3, blood pressure is 132/84, heart rate 98. And those are the last blood test. These blood tests are from April, and you'll see his A1C is 7.8, creatinine is normal, LDL is 65, but triglycerides are 250. He is fasting for this lipid panel. His transaminases are elevated. AST is 58, ALT is 78, albumin creatinine ratio. It was actually normal, but yeah. So that was in 2023. I don't have one from this year. Let's see what else. Feet exam and eye exam, they are up to date. He does not have neuropathy or retinopathy. He has had, diabetes education. He has met with our nutritionist. And again, no really kind of like important social determinants of health. He, again, he is reluctant to start insulin because, again, he believes that lifestyle modifications will help, no doubt about that, right? But again, what has happened is that he say once he gets better, but he never really gets to where he needs to be, and then he goes up again and so on. So I just worry that contributes to the delay in us getting, to optimal control. He met with a nutritionist, and this is from the visit. He does, grocery shopping is shared with a wife. They share the food preparation, no, social food insecurity, no allergies. That's kind of like the kind of food he doesn't like. He is Mexican American. He does like Mexican food, and he's 1 to 2 meals per day. Has snacks here and there. On the weekends, he might eat more. Really, he has like brunch and snacks a little bit more. He sometimes just eats, lunch and skips breakfast. This is his diet after the bypass surgery. So it improved quite a bit. So that's kind of like the most recent diet that he's really trying. He does acknowledge that at times, on weekends or when he's on vacation, he kind of like goes on this binge, and he doesn't really follow this diet. So he just came back from his honeymoon where he kind of went, was very liberal about his diet and just tried everything. Yeah, so then that's he does wear a CGM. He's been wearing a CGM for the last month. And this is kind of like, it's the readings from his CGM are kind of like in agreement to the A1C, right? Like it's like the GMI is 7.5. And I hope you can see okay there, but you can see that, right? Like his readings are kind of like high, right? Like, but kind of like highish flat with some postprandial hyperglycemia. And yeah, and then that's that. He does exercise, and he puts that in there, when he does exercise. Sometimes he does his treadmill at home, 20 to 30 minutes. He's kind of trying to do it 3 to 4 times a week.
Thank you so much, Lorena. That was a great presentation. I had one clarifying question about his weight loss journey. Tell me a little bit about how that has been going for him.
Yes, so he's been on tirzepatide for the last year. Before that, he was on liraglutide, and he has lost, on tirzepatide, he has only lost like 6 pounds in the last year. But with liraglutide, he had already lost like 10 pounds. So then, since he started a GLP-1, then I would say he lost approximately 15, 16 pounds in the last, like 2 years.
Does anyone else have any clarifying questions for Lorena? If not, we're going to go ahead and turn it over to Dr. Uneman up for the case discussion.
Okay, so just going to give a brief recap for the case. Thank you, Lorena, for presenting the case. This is just what we always go over when we have a person who has diabetes, and some of the questions that we want to just think through. What's the person's weight, kidney function, medications that they may be taking, what type of diabetes. We always, as we just discussed in the previous case, whether they have insurance and whether their cost is going to be an issue, what complications they have. And of course, one of the biggest things that we want to prevent, complications that we want to prevent, the cardiovascular risk. So for our patient that we just discussed, the patient has obesity. They have history of cardiovascular event already. They're very young, less than 50 years old, 47. No history of DKA. There was mention of a family history of diabetes. The patient has tried some lifestyle modification, intermittent fasting, but admits to irregular meal pattern. I wasn't aware of the activity, but I heard through the case presentation that he's doing some exercise, so that's good. But that would be important to know the type of exercise, the intensity, and how much exercise that he's doing. And then he is insured, so we have access to some of the great medications that can help him get to goal. And complications, the major ones, he has coronary artery disease, already has CABH, and he also has fatty liver. He is reluctant to start insulin, and that's important. So the first question that we always think about is what type of diabetes? And in this case, it's clear that this person has type 2 likely, but because he was diagnosed a long time ago and he is relatively young, he's less than 50 years old, I think it's a question that should be considered. If we do all the things that we are considering we can add on to his care and doesn't improve, we'll have to come back to the drawing board and actually analyze to make sure that we haven't missed something about his diagnosis, because he was diagnosed quite a few years ago or several years ago, and there's a chance that he could have type 1 diabetes or autoimmune diabetes, even though it's clear that it sounds like he has type 2 diabetes. And then, of course, the second question is what should be his glycemic goal? What should be his A1C goal? And we've discussed this a few times on this platform, but general goal is to have an A1C of less than 7. This is the American Diabetes Association goal. ACE has a slightly different goals, less than 6.5, but the whole idea is to individualize the targets. So less than 7 is ideal for most persons, but we want to make sure that we're not achieving that goal at the expense of hypoglycemia. So we have to consider disease features, and if someone has more comorbidities, life expectancy, and risk of hypoglycemia is high, then we relax those targets a little bit. So I'm going to ask Nicole, as we shift on to the things that we can discuss as we delve a little bit more into the case, we can break it down into pharmacologic and non-pharmacologic. We'll start with the non-pharmacologic, and we talk about things like lifestyle, diet, exercise, improvement in sleep, what we can do, and some of the things that we can offer to this patient that we're discussing today. So Nicole, you want to maybe talk a little bit about the nutritional things, and then maybe we can ask Anna to also give us some tips on how things that we can offer to this patient.
Great. Thank you, Barbara. So I think, when we're talking about how busy we are as primary care physicians and in our clinical practices, we want to make sure we're offering people different lifestyle options that are available. And so I just wanted to highlight this resource about lifestyle choices. I really like this public health blog that Harvard Public Health School does, and it has all the different lifestyles on it. And it's great for the busy clinician because it will tell you the evidence behind all the lifestyles, but it's great for the lay patient and the patient because it also talks a lot about it in lay person words, and then it gives ideas on meal planning ideas and the concept of it. And so you can send them to that website, and then they can talk about which lifestyle they're interested in a little bit more at the next visit, because we all know, when we're talking about small changes in lifestyle, it's what the patient can continue. And here I'm highlighting the Mediterranean diet just because it has been highlighted in the ADA guidelines. And I do think, this concept of like lean protein, good quality fiber, our good fats from plant-based things is part of a lot of cultures and ethnicities. And so there is a way to incorporate that into people's lifestyle. And so I was going to throw it back to Lorena just to ask her about how she talks about something like a Mediterranean diet or lifestyle with her Mexican and Mexican American patients.
Yeah, so I really try to be very sensitive to how I talk about diet, with my patients. We have to be very careful not to actually to be aware of the cultural differences. Like, I'm Mexican, right? Like, and I wouldn't like someone to tell me that tortillas are bad for me. So, right? Like, so then I try to be very mindful of that. And so I always kind of like ask what they are eating, and then I give them examples of whatever they are eating that's actually pretty good, right? Like, it's like, oh, that is great, that's actually better than this. And to make it like very friendly, and to also, patients, so they feel, that they can just tell me exactly what they are doing. I also kind of like tell them what I like to eat, right? Like, so for example, I give that example of the tortillas, right? Like, it's like, I really like tortillas, like, very much, they are actually good, like, I mean, they have calcium, and they have, we just have to be careful with the amount of tortillas that we eat, so then I try to be very kind of down to earth, and gather what they are eating and take the best from there.
Some great points there, Lorena. Comments that have come up in the chat, and something we also noticed is he's doing about 35 beers a week, which would probably be, 2 to 4 beers a day. And that might be his 500 calorie deficit he needs to, go beyond that weight loss plateau he has. So we were going to ask Anna how she brings up alcohol and just does that hard discussion about alcohol use with her patients living with diabetes. Go ahead, Anna.
Thanks. And one of the things I just thought of while listening was maybe talking to him about, or getting some kind of mental health assessment as far as the alcohol use is going. I know he's got a job that alcohol is really involved in, but is he also coming home tired and drinking a little bit more? So getting a little bit more information about where he is mentally would be really helpful. I would start out, and I tend to always start out this way as an educator, with the positive reinforcement. Look at these changes you've already made. You've got this drop in A1C. Your diet is overall changed from 10 years ago, and try to kind of encourage him to keep on that track. And then I'd be asking him open-ended questions. I think we all know that's the kind of key, and using motivational interviewing, but asking him about his use of alcohol, and if he's ever in the past limited it. Maybe it looks like he's tried intermittent fasting. He's tried some kind of diet things. Maybe he's done a dry January before, and try to kind of get some more information there, and find out what motivates him to make changes, so we can guide in that direction when it comes to the alcohol. And then lastly, maybe before all that, I'm kind of hopping around, but I would maybe provide some information to him about the effect of alcohol, along with the drugs he's using, as well as the diabetes and the MASLD, knowing that it can cause some more fluctuations in blood glucose, in addition to those calories being kind of empty calories. And hopefully together find some alternatives to drinking those 35 beers.
Thank you, Anna. And I'd also put as a lifestyle this intermittent fasting for weight loss, because it does seem like he already sort of is doing that restricted eating time period, which may have helped and supported him, but also could be sort of a memory given his job. I was thinking if he could restrict his time when he was drinking alcohol, he might end up limiting it as well. I was going to let Barbara just talk a little bit more about intermittent fasting.
Yeah, so, intermittent fasting for most persons, when particularly in this patient, there are different types of intermittent fasting. Some people can do days of fasting where they limit their feasting to a few days, and then they do days where they're fasting. That's a little bit more difficult to do, and a little difficult to sustain. Majority of persons who do intermittent fasting might do hours, and as Nicole has already mentioned, for this particular patient, I think that might be something that would help, especially if he's had issues with binge eating when he's gone on vacations and things like that, if he can maybe stick to that plan where he's doing intermittent fasting and doesn't start eating at a particular time and completes his feasting at a particular time, that might help him actually be a little bit more disciplined. So there are quite a few studies that have shown that intermittent fasting, when people adhere to, can actually allow them to stick to their plan a little bit more better in terms of keeping their calorie intakes down. So we have mentioned about his liver issues and the fact that he has MASH. I put this slide in here just to talk about management of non-alcoholic fatty liver disease and in persons with diabetes, and the different medications that we can consider using when people have this condition as well as diabetes. And really, this is just to give people an overview that we don't have a particular approved medication per se, but we just talked about pioglitazone and how, if you look on the fourth, I guess, or fifth row, you see that it's the agent that consistently is considered to be potentially effective in reducing persons who have MASH. So reducing the effect of the steatosis or the accumulation of fat in the liver. So we just put this in here, and we can come back to talk about that in later slides in a few minutes. Tirzepatide, which he is on, has also recently been discussed in the literature. This has had a lot of buzz lately, and as recently as July, there was a paper published in New England Journal looking at the effect of tirzepatide on metabolic dysfunction associated steatohepatitis with liver fibrosis. And really, the conclusion was that in patients with MASH or moderate and or severe fibrosis, if they took tirzepatide, there was a signal that they had significant improvement. Fibrosis did not improve, but the accumulation of fat improved. And this was the first one of the GLPs that actually showed a significant improvement. Prior to that, another paper had shown that there was no significant improvement in fibrosis. And that was the paper that was published in 2023. So there's a signal here that GLPs can also help with this condition that we're talking about. And fortunately, he's already on tirzepatide. It's interesting, though, that he hasn't lost a significant amount of weight, because at 15 milligrams of tirzepatide, if you look at the studies, majority of about 50% of persons would have lost about 15 to 20% of body weight. And it looks like he's on the lower end. So that needs a little bit more investigation, and maybe lifestyle needs to be focused on a little bit more for him. So the question now is, does he really need insulin? We know that he doesn't want insulin. Could we consider another agent? And I think pioglitazone could work here to improve glucose, get him to A1C target, and also help with MASH. So for this person, we know that weight is an issue, but I think there's a lot of things that we can work on to address the weight issue, whilst adding on a medication that potentially could give him a little weight gain, but has a lot more benefit. So we're always doing risk-benefit analysis when we're choosing medications. And in this case, I think pioglitazone has a little bit more to offer him in terms of benefit compared to the risk of weight gain that he could get. And when we think about the effectiveness of pioglitazone, this is an old paper, but if you look at the effectiveness, and we just talked about it, it can reduce his A1C by up to 1.5%, which would get him to goal. He has high cardiovascular risk. He's already had an event. He's already had CABG, basically, early premature cardiovascular disease, and his lipids are not ideal, even though they've significantly improved compared to before he had the event. So just looking at his lipid profile prior to his event, it appeared that he was not on optimal statin therapy, but he's currently on optimal statin therapy. And his total cholesterol is less than 200. His triglycerides are still above target, and his LDL is 65, HDL is 41. And the question is, what should his goal be? So I'm going to ask if Savita could give us a little bit information on, in this person, what should we be thinking of about? He's already on a high intensity statin, we probably would think about using, maybe adding on ezetimibe, but will this be a candidate for a PCSK9 inhibitor? Should we be considering using fish oil or for him because of his triglycerides, and what other things should we be considered about?
Yeah, so yeah, this gentleman is quite young. He's 47 and he already has a 3-vessel cabbage. So that is, Dr. Onuma mentioned, is premature cardiovascular disease. So in someone who's had diabetes for many years and maybe suboptimally managed and suboptimally treated lipids, this is probably the reason why diabetes is a cardiovascular risk equivalent. And if you have suboptimally managed hyperglycemia and lipids, you can develop cardiovascular disease, and that's typically multi-vessel. And so he had 3-vessel disease, which is quite typical. So in someone like this, premature cardiovascular disease, high risk ethnic background, diabetes, high BMI, that's already 3 or 4 risk factors right there. He needs to have an LDL goal that's less than 55 milligrams per deciliter. And this is so in the AHA guidelines that we normally tend to use doesn't actually state this, but if you look at the ADA guidelines as well as if you go across the pond to the Europeans, this gentleman is very high risk, and so you do really need to add therapy to get him lower. This is from suboptimally managed lipids and diabetes over the years. So going forward, to keep his grafts open, he really needs to manage his risk factors pretty aggressively. So yes, so as Dr. Onuma has here, so the next step would, if you ezetimibe in combination with a statin will give you up to 25% drop in LDL cholesterol, and he's at 60 already. And so if you added ezetimibe, you'd get him down to under 55 easily. Can you argue for a PCSK9 inhibitor? Yeah, yes, you can. But again, if you can use the medications to get him to goal, I would probably go that route for someone like him. But again, this is a discussion you can have with the individual and decide. It all depends on how you word it, and this is a very high risk individual. There's a possibility you can get it covered, but it depends on his insurance. Some insurances want ezetimibe as an intermediate step before you go to PCSK9. Some do not these days. So that's how I would start with ezetimibe. With regards to fish oil mixtures, OTC, not recommended for anyone. Specific question for icosapent which is purified fish oil, branded Vasipa. This gentleman would fit the REDUCE-IT trial criteria. So that was the trial which looked at icosapent for people who had already cardiovascular disease or high risk factors. So he falls in the already pre-existing CAD and diabetes. And so the folks who got the Vasipa had quite a striking decrease in cardiovascular risk, so up 25% or something. And that was independent of triglyceride levels. So yes, he would be a candidate for icosapent but you'd have to, the dose is 4 grams and that's 4 pills. So cost is also sometimes is oftentimes a barrier if it's not covered on his insurance plan, and you do have to take the 4 pills. Some people, it's pill burden. So I do think it is definitely something to consider, but I'd do the ezetimibe first before I went Vasipa.
Thank you. And he is now optimized on high intensity, but for a person such as this, it was definitely not a good idea for him to have been on pravastatin 10 because that was suboptimally controlling his lipids. So we already talked about this. Just to quickly go over a few things here. He is, just to mention, in his case, he is on tirzepatide, which is an excellent medication for glucose lowering in terms of its efficacy. But because we are trying to make sure that we are doing evidence-based, I want to make sure that we all understand that we don't have the cardiovascular outcomes trials out yet for tirzepatide, and this gentleman has a high cardiovascular risk. So certainly if we wanted to use a GLP that has cardiovascular data, it would be either dulaglutide, liraglutide, or semaglutide, because we have published cardiovascular outcomes trials on those particular GLPs. We know for sure that the other ones are coming. The one for tirzepatide is going to be probably published before the end of this year or early next year. But we just want to make sure that I state that we do not have CVOT outcomes trials published data yet for tirzepatide. And last but not least, he has obstructive sleep apnea, and his obstructive sleep apnea is being investigated, and tirzepatide has been shown to actually improve the sleep apnea metrics in persons who have sleep apnea, both persons who are getting treatment with positive airway pressure as well as persons who did not. In this trial, they did two arms where people got tirzepatide whilst they were getting sleep apnea treatment with POP and sleep apnea treatment and no sleep apnea treatment, and they still found a significant reduction in the apnea hypopnea index, which means that there's a signal here that tirzepatide could certainly improve the sleep apnea metrics for persons who have obesity and sleep apnea. So this could help him as well. So there are lots of factors that he's already going to benefit from continuing the tirzepatide. However, in his case, I believe that there are several areas that we can perhaps maybe enforce, and that would be working a little bit more with him in terms of diet, exercise, getting a little bit more structure. He is already following up to see his sleep medicine person, and most importantly, maybe working, and if needed, getting assistance to cut back or eliminate the alcohol intake, because I think this will affect several of his metrics. It would improve his triglycerides, it will help the liver stuff, and also reduce the caloric intake. And pioglitazone may be helpful in improving glycemic control, and also may not significantly affect his weight if we all work on all the things that we've discussed. And as we already mentioned, adding ezetimibe to get him to a target of less than 55. And that's all I have.
Thank you so much, Barbara. That was great. And we are over time. So I just wanted to highlight that there's been some great things in the chat, especially about the alcohol use, and then about his potential increased risk for pancreatitis because of the appetite and his alcohol consumption. And so I'll just end with this thought that it's all about what motivates the patient. So maybe sharing that risk for pancreatitis might be a motivator, sharing the calorie intake might be a motivator, talking to him about need for support if he is abusing or addicted to alcohol would be all great things. And it's all about motivational interviewing is what we heard about in the chat. And so helping patients set his goals. So on that note, we'll say this ends session 4 of the cardiometabolic echo.